First, I want to comment that I am really sorry that you and your colleagues are on strike for better working conditions and better treatment conditions for your patients. I think it's a terrible situation, and it's made worse by the fact that the needs for mental health care have never been greater in society. There's never been greater recognition of how much depression, anxiety, stress, trauma is prevalent across all parts of society. Uh, uh, Part of that is COVID, part of that is issues around social justice and racism, part of that is the stress that we're feeling in society at large. So I am really disturbed that you're not able to do the work for which you are so well qualified. And burnout. One of the things that I do, I'm a professor of psychiatry at the University of Toronto and just recently completed a term as president of the American Group Psychotherapy Association. One of the things that I do at the University of Toronto is facilitate communities of practice for healthcare leaders coping with COVID and the impact of COVID and related stresses that I mentioned earlier. And what is so clear is that burnout, compassion fatigue, is more prominent now than it's ever been. 50% of healthcare providers in some surveys before COVID reported feelings of burnout. And now the numbers are off the charts. And we know nurses are leaving, they're retiring, physicians are leaving and retiring, psychologists are leaving and retiring, social workers are leaving and retiring or moving on to something else because the work has just been too difficult. And it's important that we recognize that although it's experienced at the level of the individual, it is a systemic issue. Burnout is more prominent in environments where certain conditions that enhance the safety and well-being of providers are not met. And this is doubly important because there is some very interesting research. It was published recently in Psychotherapy Research that looked at the impact of the culture of the organization on clinical care. And it's something that has intuitive sense, makes intuitive sense, but when you actually see the empirical evaluation that shows that the contribution of organization to the delivery of care through the culture of care contributes up to 6% of the variance in outcome. 6% brings us up into the range of model, brings us up into the range of therapist contributions to treatment. So it is significant. And that's why it's so important that you be successful in your strike, in your protest, in remediating the challenges you're facing work-wise, because it comes from the top and trickles down through the organization, the team, the individual provider, to the patient, to the client. And healthier organizations have healthier engagement with their staff. And there's a lot of evidence that shows that the more engaged the staff are, and that comes from good alignment around values, principles, the higher the engagement between frontline staff and the organization, the better the clinical outcomes, by a factor of 2 or 3-fold. So I'm sure I'm not saying anything to you that is coming as a surprise, but it's important to know that this is not a kind of motherhood and apple pie state, but that there is evidence to support this. So, and I'm always a big fan of when the science supports the wisdom. we do not do good work when we are feeling stressed, undervalued, and we are confronting so much trauma in our clinical work. The exposure vicariously to other people's trauma, our own experience with trauma. And COVID, I think, has brought this into everyone's life. Um, we do less good work when we are less emotionally available because we are feeling overwhelmed or devalued, dismissed, unsupported. We have all had the experience of treating um, a parent who is dealing with trauma, and we know how hard it is for them, despite their best intentions, to be emotionally present and available to their family. And the same appears to be true for mental health providers, psychotherapists, for group therapists. So we need systemic solutions. We need our leaders to be not penny wise and pound foolish. Well, I've spent my entire career working in teaching hospitals. So I work closely with medical colleagues, surgical colleagues.
Mm-hmm.
And the model that you're describing of 30 people attending a group, there is some value for that as a psychoeducational first step, a kind of base of the platform,
Mm-hmm.
a base of the pyramid. And then you increase uh, uh, the intensity, the focus as people need more. But to assume that you're going to meet the needs of people by putting them into a group of 30, I think is naive and foolish. There's a role for that, but for that to be the totality, I think is really misunderstanding the value and effectiveness of group therapy. In the textbook that Irv Yalom and I recently authored, The Theory and Practice of Group Psychotherapy in the 6th edition, we do a thorough review of the literature on outcome and group therapy. And the evidence is powerful. Group therapy is a triple E treatment. It is equivalent in outcome to individual therapy for most people. And where it's not, it's generally superior for people who deal with issues around stigma, social isolation, who need peer support or peer pressure. The second E is that it is effective. There was a recent study by a researcher by the name of Janice, published in 2020, that it was a big meta-analysis of group psychotherapy in the treatment of depression. And their research showed that across modalities, if group therapy is delivered properly, participants in group therapy were 7 times more likely to benefit from group intervention than people who did not receive care. So it's a powerful, effective treatment. And the other part, which is kind of really hard to make sense of in managed care or kind of third-party payer systems, is that group therapy is efficient from the perspective of the provider. The efficiency value is of a factor of anywhere between 4 to 8. So 1 hour of group therapy, group therapist time, can provide care to 8, 10 people. I think that the model that you describe is using the group as a kind of setting for delivering some kind of intervention, generally an educational intervention. But I think group therapy is way more powerful, way more potent when the group is used as an agent for the intervention and not just a setting, not a classroom. What does it mean to use the group as an agent? Is that you maximize the opportunities that come with understanding group dynamics, group interaction, group process, group development. and how to maximize peer support, how to maximize cohesion. And there are models of group intervention that show good effect in very time-limited groups. And even if you're running a group, a DBT group, a CBT group, 6, 8, 10 sessions for depression, anxiety, trauma, the more attention you pay to process, the more effective you're going to be. And we did a survey 3 years ago, the American Group Psychotherapy Association, of a number of agencies in New York who together had responsibility for care for about 100,000 individuals. So this was not a small sample. All of them are using groups. All of them felt they were not delivering group therapy as effectively as they could because people were tossed in, group leaders were tossed into a treatment environment without a lot of training, often, without a lot of support, given a manual. And it's like a cookbook therapy. And again, the evidence there is very robust that adherence to a manual is not in any way associated with good outcome. It's how you use the therapeutic relationships that is associated with better outcome. So there are a lot of things that we can do better. And I felt strongly that there are two gaps that are important for us to address as mental health professionals. One is the quality gap, that we know what good treatment is, but we're not delivering enough. And related to that is the implementation gap of how do we translate what we know into accessible treatment. And my belief is that we would go a long way to reducing wait lists and increasing access to care if at the first access point, people got access to good quality care. That would save us a lot of wear and tear. It would reduce burnout, because burnout arises when you feel overwhelmed and feel that you're ineffective and not able to do what you want and need to do, and you're battling the moral distress and moral injury of working in that kind of environment. And it would also safeguard patients who need care, saying, that was terrible. That didn't help me at all. Why would I waste my time? So we are unwittingly reinforcing stigmatization around mental illness by providing less than best care. Some opportunity for interaction, some opportunity to capitalize on peer support, some opportunity for peer-to-peer learning. For many years, I led groups for women with metastatic breast cancer. And there was, by design, nothing interpersonal in those groups. The focus was on coping, dealing with the symptoms of the illness, improving communication with the oncologist, improving family communication, dealing with death anxiety. But all of the groups were informed by an understanding of the importance of cohesion, of group process. We didn't explore interpersonal relationships principally, but we were aware of the relevance of that because it makes you a better group leader. You know what to emphasize, what not to emphasize. In the same way that the best supportive psychotherapy is dynamically informed.
Wow.
Yeah. So that's a big challenge, and I think I hope that you can fix that system. But if you're stuck with that system, what you can try to do is to embrace the problem by providing individuals before they come into the group with material, digestible, easily accessible material about what to expect, how they can make the best use of the group, not covering up the difficulties, but recognizing them.
Even perhaps.
Well, I think we look at selection criteria for group therapy, and I think that there are two ways I can answer that question. One is through the lens of the therapeutic alliance. In order for people to benefit from any kind of treatment, they have to be able to establish goals. They have to be able to identify tasks that help them towards those goals. And they have to have a therapeutic relationship that supports that work. So nothing good happens unless you have good alignment between the treater and the client about the goals, the tasks, and the quality of the therapeutic relationship. So who should not be in a group is someone where you don't have that kind of alignment, where their goals are not aligned with what you're providing, or that they're not able, they don't have the wherewithal to fulfill the tasks of treatment. So, but the beauty of group therapy is that the condition that might lead you to be unacceptable for, or to be discouraged from participating in one kind of, might be the ticket of entry into another kind. So groups for patients with affective dysregulation, patients like that don't do well in a process interpersonal interaction in a group. They need more structure and more support for affective regulation. But putting people like that in a DBT group that's homogeneous for that kind of level of distress can work very, very well. And there's mounting evidence that people can benefit from kind of lower intensity DBT treatments, for example, that we don't need to look at a whole year. People can benefit from more focal kind of DBT.
Somewhere closer to 8 to 10.
30 people is not group therapy.
Yeah, I can speak to that as a DBT provider. Our DBT groups, because they're so small, we have less than 10 patients. It's 2 hours long. We actually do get to have some peer-to-peer interaction, peer-to-peer support, peer-to-peer processing, which is really where the transformation happens in group psychotherapy. For most of the Kaiser groups that patients are pushed into, they are classes being taught from a PowerPoint.
Yeah, that's not gonna treat people. What you just described, Helen, in terms of kind of DBT work, that treats people.
Yeah.
And if people don't get good treatment, as I said, it adds to stigma, it adds to costs. And again, it's being penny wise and pound foolish, because we know good treatment reduces costs. People don't make the same number of emergency room visits. They don't become medically ill. You're not treating the consequences of self-harm. I'm sorry that you guys are in the situation that you are in. I wish you strength and solidarity. It's a Pete Seeger song, Solidarity Forever, I think comes to mind. I just heard it on the radio the other day. I heard the whole song, and it's very powerful. And my association to that also is something that Judith Herman has written about with regards to dealing with trauma. She said the solidarity of the group is the best response to trauma. Here, the group is you guys, you and your colleagues, and the people who are working to create healthier work conditions for therapists so you can do your invaluable work with the thousands of people who are coming for care at Kaiser. And, I hope that Kaiser honors their reputation.
Placed a power greater than their hoarded gold, greater than the might of atoms, magnified 1,000-fold. We can bring to birth a new world from the ashes of the old, for the union makes us strong.